Okay, so our CVA symptoms. So as we mentioned from the outset, that it's a sudden focal deficit, right? It's a sudden blockage or sudden hemorrhage of a vessel, and it's going to cause a deficit of the area it feeds, whether it be the PCA, MCA, ACA. Any specific area of the brain is being affected, right? The specific thalamic bleed, right, is being affected. The Broca's area of the motor, of the temporal lobe being affected. All of a sudden they cannot speak. All of a sudden they cannot say their name, right? So like we had a patient that was, a young patient in the 20s, and then the doctor goes in there, another doctor goes in there, they write the note, patient's fine, and then we go in there and he says, tell us your name. They can't talk. Can you talk? He shakes his head yes, but then he's like, okay, so we'll say your name. He can't say his name. That's a sudden focal neurodeficit. All right, and we were mean. We got the doctor to tell us how you got him to say his name, right? So that's it's like you can't say it. So then, but we did a stat CT scan. Sure enough, there's a mass there, right? So it's something to assess. Is there a sudden deficit, right? Or is there something suddenly that's causing a focal deficit, right? It can happen over time, right? Such as a mass itself, right? You have a neuromass of some sort, a brain mass, that can cause a slow focal deficit developing over time, right? This guy was in the ICU for like 2 days, right? He went through all the nurses, and mom was at the bedside the whole time, kind of answering for him. So it's kind of where the disconnect kind of happened too. But at the same time, we have a brain mass that happens over time, does have a focal neurodeficit, right? But was it sudden? No. If it's sudden, that is what a stroke is, right? So we have mimics for strokes. We have things that can mimic a stroke. You can think of the mnemonic behind is something. And the B, besides brain mass, the first thing you think of is blood glucose, right? What is my blood glucose? Do they have a history of diabetes? Are they on insulin? Because that's going to also cause a sudden neurodeficit, right? So that's why we look at all the stroke pathways. They always say do a glucose first, right? ACLS says check a glucose first because it causes sudden focal neurodeficits. All of a sudden they can't speak. They have slurred speech all of a sudden. They can't move their arm all of a sudden, right? So these are stroke mimics. E for epilepsy. So when you have a seizure, you're in your postictal state, they can have focal neurodeficits, right? All of a sudden they can't move their right arm, or all of a sudden they were incontinent, right? When before they were continent. That's one of the clues that it's an actual seizure. They become incontinent, right? But also you have some good actors out there that will pee themselves. It's like, oh, I need out of van. But it says, but there's some psychiatric reasons for their psychogenic seizures. All right, but then we have hyponatremia for H, right? So they got, or hypoglycemia as well, but your sodium being low, right? Sodium is all about the CNS, right? Sodium equals CNS, and that is a characteristic of your sodium getting lower and lower and lower. It can cause a focal deficit. It usually causes confusion and such, and seizures for that matter, but it's something to consider, right? And then we have infection. So there's some kind of infection that's brewing, like an abscess infection, because when you have just like a encephalitis or meningitis, it's usually global altermentation, right? Usually after a while, like after like 5 days, you might get some focal deficits. But usually initially for the infection process or for it's usually a global deficit. But if it's like an abscess that's forming, that's going to be an abscess in a specific area, and that specific area is not going to work, right? So an abscess of some sort. And we have migraines. Migraines can develop a specific area of the brain is losing its blood supply or spasming, and that can cause focal neurodeficits, right? Usually someone knows they have migraines, they have a history of migraines, they have an aura before they get the migraine, so that's a clue that you might have a migraine instead of a stroke, right? Sorry, yeah, a migraine instead of a stroke. And then multiple sclerosis, that's a progressive disease. They have a history of multiple sclerosis, and that causes a plaque formation in a specific part of the brain, and that part of the brain no longer works. It doesn't come back, and it's a progressive disease that happens over time, right? Hypertensive encephalopathy, that kind of didn't know where else to put it, but if you have really, really bad hypertension, it can cause a focal deficit as you recover. If it didn't cause a stroke or it didn't cause a bleed, it can cause this lack of function in one specific area of the body. And of course, being drunk, right? So you have cerebellar dysfunction. So it's a specific area of the brain is not working. And then of course, doing ETH levels can let us know if someone has ETH as part of the reason for their neuro symptoms, their focal deficits. Right, especially if someone just not waltzes in, but walks in drunkily. They might have a cerebellar stroke, they might have an ACA stroke, they might be drunk. So we got to figure out, and just doing an ETH level can help us figure that out. All right, but either way, what you're going to ask them is, when was the last time known well? or last known time well? When's the last time you were able to walk good? Or when's the last time you were able to, talk good? Or when's the last time you're able to have full function of your face? Right? They smile and they have a droopy face. You got to get their last known time well. All right? And the whole purpose of that is for thrombolytic therapy, because thrombolytic therapy can fix a stroke potentially with a 7% mortality, but it's still an option for them. So we have to activate the pathway. We have to call a code stroke when we identify someone has a sudden neurodeficit that is focal, and also one that has a sugar that's normal. All right, those two things together, you got a patient in front of you that can't talk, you got a patient in front of you that can't speak or has a droopy face. All right, then that's a sign that we need to call a code stroke. Okay, and then are we doing an NIH stroke scale before we call code stroke? No, you're going to do it before we give thrombolytics. And it's also going to be done by the provider. They're going to assess what's going on. And usually when you're on the middle range there, it's safe to give TPA or give TNK, thrombolytic therapy. When it's too low, then the risks outweigh the benefits. When it's too high, the risks outweigh the benefits as well. Right? But it's usually that sweet spot in the middle when the stroke's not too big and it's not too little. When it's just the Goldilocks zone, that's perfect, right? Because as we mentioned before, with an ischemic stroke that's way too big, it can actually cause hemorrhagic conversion. Right, so we don't want to potentiate that with giving thrombolytics. All right, so you have a whole separate class or a whole separate module on NIH stroke scale. So I'm not going to go through all the things there, but some of the things that's like biased is that it's really all about MCA as well. And there's very few PCA activity that's looking at, right? There's no frontal lobe activity or assessment. You're not saying, what would you do if someone stole your sandwich in the break room? Would you put laxative in their drinks? It's like, yeah, I would. All right, so that's not part of the NIH stroke scale, right? Same thing, is there vision checks? Yeah, yes, that's occipital lobe, but that's also MCA, right? So it's kind of more biased towards MCA strokes. Correct. All right. So yeah, so there's 11 areas. You get 42 points, right? The life, universe, and everything. So an increased number usually means increased mortality as well, right? It usually means that they're the high risk of going to a hemorrhagic conversion. Okay, we'll talk about hemorrhagic conversions as well. All right, so that's the idea behind these strokes, right? And this gentleman's having a stroke in the gym.
This man is having a stroke right now. During his
He
workout,
has
there's a
facial droop.
blood clot in his brain. It's subtle, but look at his face. There's asymmetry there. Both sides are not moving in the same way. He's also off balance, unable to pick up his glove. Coordination is not there. That's another sign. Look at his face, asymmetric. Now is the time to act fast. And every second that the clot is there, blood is not getting to an area of his brain, and brain cells are dying. They're not coming back. It's irreversible. With stroke, it doesn't have to look serious for it to be serious.
My right arm is drooping too. Okay, so yeah, so it's important that the public recognizes it because it's not painful, right? If it's a hemorrhagic stroke, yes, it's going to be painful. But if it's because we've had patients come from the gym with hemorrhagic strokes, because probably have some hypertension undiagnosed as well, but they have an ischemic stroke like this, it's not painful. So recognizing, be fast, and getting out in the public so they know that, hey, that's not normal for me to be losing my balance and not be able to have coordination. All right, and then as we talked about, the A is for the legs, the M is for the arms, M is also for the mouth, and P was all about the eyes, right? The posterior circulation. B is not represented here, the basilar artery stroke, but you can see that PCA stroke is all about the eyes as well. All right, so our diagnostic tests. So what diagnostic tests do we do for strokes? Well, obviously ETOH level, like we mentioned. You're going to try to rule out other things that could cause a stroke, and also you're looking for those causes of stroke we talked about at the very beginning, right? A CT scan is done, so CT scan is going to look for blood, right? If there's blood there, then we know that they have a hemorrhagic stroke, and we can't give the therapy of thrombolytics, right? Thrombolytics are usually our Hail Mary to try to get rid of the clot that might be blocking the stroke in ischemic strokes. So we're looking for, is there hemorrhage there? Then they can't get thrombolytics because then that's going to cause bleeding, right? And also we're looking for ischemia. Well, I thought you were looking for ischemia for ischemic stroke. Well, how long does it take for ischemia to develop? About 12 to 24 hours. So that's not okay. That means that it's been more than 12 hours. If we gave thrombolytics at this point, it would cause hemorrhagic conversion in of itself. The risk is extremely high of hemorrhage when you give thrombolytics after 4.5 hours. Okay, so CT scans are done, and they're super fast to do. Well, why not MRI? Because it's actually the fastest recognition of a stroke, right? Within minutes, it can tell you you have ischemia, right, on an MRI. But have you ever done an MRI checklist and you have to call the cousin, hey, you've been shot, right? And he's like, have you had a pacemaker, right? Do you have your pacemaker card, right? And you have this, you have that. It's like it could take a while to go through all 21 questions or 30 questions in this example, right? So it takes a while to get through it, and then to get them down there, you can't go through all your IV pumps. So if you're on like nicardipine for a really high blood pressure, that you can only go one drip at a time. So it's a whole to do, right? There's MRIs nowadays at big centers that can be a little more forgiving, but it can take about an hour to complete the whole study, and that's including transport. So CT scans, you have 15 minutes there and back, and you got an image, right? So that's why we do CT scans. If you see dark gray or you see a hemorrhage, then it's not a candidate for ischemic stroke therapy, acute therapy, which would be a thrombolytics, right? There is other options out there. If it's been within 24 hours, we can go in there and yoink the clot out. We can get the clot and vacuum it out, or grab it and take it out. That's called a clot extraction, right? It usually has to be a large vessel though, and we'll talk about that. Okay, so MRI is safer, less radiation, but it has a lot more contraindications compared to CT scan. Right, and then labs, CVC, remember we have that abscess that can form, we have infections that can maybe present with focal deficits. We're looking for the sodium level in our CMP, the blood glucose. Do we need to wait for a CMP? No, we get a point of care glucose with our AccuCheck machines. And then drug screens to see if there's any drugs on board, any ETOH, any fentanyl use, any other illicit drugs that might be causing a acute change in their mentation, right, or in their focal deficits and their neuro deficits. And then an echo, what's the purpose of the echo for? So look for the valves, yeah, see if there's any kind of suspicious valves that might have clots on them. Look to see if there's a clot literally in the atria or in the ventricle itself that might be in transit into the brain. Okay, and then carotid ultrasounds, those are looking at the carotids, right, to see if there is blockage brewing in there, right? If there's blockage in there, oh, that's why you had absent blood flow, right? That's why you had a situation. Either it can block up completely, or a little piece of it can break off, a little atheroma can break off, right? And then we have 12 leads. 12 leads can look for that AFib. If they have AFib happening, a 12 lead can let us know if maybe that's why they developed this acute stroke, right? So you can ask them, are you on anticoagulants at home? Oh yeah, I stopped that when I had my surgery last month. It's like, well, we should have resumed that, right? That might have been the reason for our stroke at this point. Here's an interesting open heart patient. You can see the actual atria fibrillating there. They're really just going to town, right, with AFib. So of all these tests, what do you do first? Well, you got to assess them if within 10 minutes is the goal for the RRT nurse and for the ASLA nurse or the provider. You have to, within 10 minutes, decide if someone has a stroke in front of you or not, right? Especially if you are a stroke center. And you have to then activate the stroke team within 15 minutes of arrival, right, of assessment. And then after that, you get a CT scan within 25 minutes, right? It is all time to track. There's someone downstairs, that's their only job, 40 hours a week, is to make sure this stuff gets done, right? So they're looking to make sure, hey, CT scan is 26 minutes. Well, you do better next time. It's like, okay, yeah, I had my other patient was coding, sorry, right? But that's why we have more resources in the ICU to get these things done. You have to let your chargers know, say, hey, my patient's having a stroke, let's can you take a look at them? You have the RRT get in there, say, oh yeah, you're definitely right. It's called a code stroke, and get this evaluated, right? While you attend to your other patient that might be coding, and they're probably nearby anyways, right? So we have these different guidelines, which are ACLS driven and American Stroke Association driven. And then, of course, the CT needs to be read in 60 minutes. And if it doesn't, that's radiology's fault, and they're going to be on them to get their times improved. And then it's up to us to give the drug, the thrombolytics, within 60 minutes, right? That's the goal with thrombolytic drugs. If they meet criteria, then it should be given within 60 minutes from the recognition of this stroke event. And that's why we call it code stroke in this situation. All right, so the acute treatment, how do you fix it? How do you fix it with those thrombolytics? All right, thrombolytics, yes, they're great. They're only for within 4.5 hours of last known time well, right? So within 60 minutes of a code stroke, that's when it needs to be started and administered. Okay, there's two varieties. You have TPA and TNK. We have TNK here, all right? It came into widespread use about 3 years ago. And so they have to be able to get the TNK if they meet criteria, right? And one of the criteria is a blood pressure that's good, right? Because if the blood pressure is too high, it's going to break clots and start bleeding out into the periphery, into the brain. All right, and if it's beyond 4.5 hours of the last known time well, then what else can we do? Are we done? No, we have a clot retrieval. We can go in there through the groin, and we can then just yoink the clot out and take it, yoink it out, right? So they have to meet criteria for that as well. So it has to be within 24 hours of last known time well, and we have to meet criteria on this scale right here. So they say it Van positive. So it's any one of these. It doesn't have to be like all three. So do they have any right gaze or left gaze? Do they have any aphasia of any sort? Do they have are they ignoring one half of their body or not? That tells you we have a large vessel that's being occluded, an LVO, a large vessel occlusion, and therefore they are a candidate to take out that clot, right? And has a lot less complications compared to TNK and TPA thrombolytics, right? Thrombolytics have a 7% mortality, LVOs don't, right? So I'm not sure the mortality is, but it's extremely low, okay? So when can you not do this? Well, you can do it if they failed TPA. You gave TPA or TNK and they still have the deficits. It's like, well, I got something else we could do. We could go ahead and do one master poke, all right? Because you're not supposed to poke your patient after TPA, TNK. You're supposed to get all your IVs, all your ABGs, everything done ahead of time for 24 hours. But we can go in with the catheter here, post-failed thrombolytic therapy, right? But what can happen if you have a bad user error, right? They go through the blood vessel wall, right? The clot can dislodge and go further down and cause, that's a complication that we know that we're going to try to capture, but it might just wash away, right? We don't know if it embolized for carotid or if it is a thrombus right there that developed. And then BP management. So I told you BP was a little bit tough. We'll come back to BP again when we talk about hypertension, hypertensive bleeds. But if they're getting thrombolytics, they need to be, we don't want them to bleed through the weak part of the vessel, right? So 185 over 110 is before administration and 180 over 110 after. So why could you guys make it the same? It's like suckers, right? And they sped off. I don't know what happened. They never responded on my emails, right? But after that, that's that's how the studies were designed, unfortunately, back in the day. So that is the goal. So 185 over 110 pre and 180 over 110 post administration is what you want the blood pressure to be, right? If they have an ischemic stroke and if you're giving thrombolytics. What if you have an ischemic stroke and you're not giving thrombolytics? That's where you would just let it ride until it's more than 220 for 120. If it's more than 220 for 120 and they have an ischemic stroke, not a hemorrhagic stroke, we're not going to let that ride, right? Otherwise, you're going to bleed more. So if they have an ischemic stroke, not getting thrombolytics, then we could go ahead and do what's called permissive hypertension for the first 24 hours. Sometimes someone will say, oh, Aaron told me permissive hypertension, my patient's blood pressure is 210, it's day 5. That's way too high, right? So it's 24 hours. And then every day after that, it's another like 10 to 20% reduction in the blood pressure, right? So 10% of something is just moving the decimal over, right? So if the blood pressure is 210, that means you're reduced the blood pressure by 21 points, right? By the end of day 1. Right, so if they're running like 210s, then 190 is perfect. That's where they should be, right? By the end of day 1, by 24 hours, and then next day, so that's 10%, right? 20% would be 40 points, right? So 42 points technically. Sorry, I misspoke. So you have, I got it. 10% is 21, and then you want a reduction about 20% within the first 24 hours, right? So by the end of 24 hours, about 42 points of reduction is where you want to be. So that'd be where? Be about 170 to 210. You want to start coming down slowly down to 170, not anything less than 170. Okay, if you do, you can get what's called a watershed infarct. All right, we deliver blood to this vessel over here. We deliver blood to this MCA over here. So the ACA got its blood supply, the MCA got its blood supply, and you have a blockage of that artery there. So what about this area of potential ischemia? Bring the blood pressure down too quickly, this area of ischemia is going to get more and more ischemic because this blood supply was providing the blood. There's like a hose, right? We had the hose turned up full blast, and we turned the hose all the way down. We reduced the blood pressure. Look at me, right? And now the blood flow is reduced in this whole area because you reduce the flow to the area. The area is going to get a widespread infarction. Okay, it's called a watershed infarct. Okay, and then of course watershed infarct, and that can lead to further low blood pressures, further low oxygen states, further cerebral edema, and death. Okay, so what else? So we have to get someone's blood pressure under control for thrombolytic therapy, right? Or for ischemia, if it's more than 220 over 120, can we give PO meds? No, not until they've passed a swallow eval or a speech language pathology has said it's okay for them to swallow. All right, but usually in the acute stage, if it's time to get thrombolytics, we're going to say, hey, take this. I'm going to wait 30 minutes for it to kick in, and then in an hour, we're going to check your blood pressure, see if it's good. All right, so now it's 5 hours. Am I out of the window? Oh, I'm sorry. You missed the window. I don't know what to tell you, right? I wish your stomach would work better, right? Or you do better next time. Right? So it's my own brain trying to compensate. So we have other IV agents, right? We got PRN labetalol, PRN hydralazine, enalaprilat is an ACE inhibitor IV form that can be given to lower someone's blood pressure. If that's not doing the trick, we can do an IV nicardipine infusion to get the blood pressure under 185 or 110 if they're going to be getting thrombolytics, right? The blood pressure like 240s all the time and they're outside the window, then yeah, we can do that for ischemic strokes too, for ischemic strokes that are not thrombolytic candidates. All right, and then within 24 hours, you're going to be giving antiplatelets and anticoagulants for VT prophylaxis. And you can slap the SCDs on right away. That's perfectly fine. But aspirin, you can wait till the 24-hour mark. That's where we want to start the next day. If they got thrombolytics, we don't want aspirin and thrombolytics on board at the same time, so we are going to wait 24 hours. Okay, but within 24 hours, right, you want to at least get aspirin started. The addition of DAPT or clopidogrel is dependent on the neurologist and what other kind of factors they might be brewing. So they may or may not be on DAPT, but they definitely be on aspirin for life. And statins are also protective, free radicals and such, and with healing, but also it's for cholesterol, because we know that most common strokes are due to cholesterol buildup, right, from causing atherosclerotic cardiovascular disease. All right, and then pharmacological treatment with either would be heparin or Lovenox, and of course our SCDs for mechanical VT prophylaxis, because these guys are going to probably bedbound for at least 24 hours, right, especially if they got thrombolytic therapy. And then to avoid any kind of secondary injury, we make sure the sugar's good, the blood pressure's good. That's up, a little asterisk there. It depends on what the blood pressure situation is. Euoxia means normal oxygen states, normal thermia, and we have everything normal. That's the goal, right? pH, CO2, everything should be good so we avoid secondary injury, right? So we're looking at blockages here, and we can go in to take out the clot via a large vessel occlusion if they are VAN positive, right? And if they aren't, if they are beyond 24 hours, then it's just managing ischemic strokes. But hopefully we've taught and done education that they come to get help as soon as possible, as soon as they have signs of a stroke.